Good morning. It is Tuesday, October 12th. Welcome into the Morning Medical Update. We are live inside the Dolph Simons Jr. Family Broadcast Studio. Today we are taking you inside the scenes of our hospital. You are looking live just outside an operating room where the 100th patient to receive intra-operative radiation therapy, also called IORT, is happening this very minute. This radiation therapy is FDA approved for breast cancer patients who catch their cancer early. It allows them to have the cancer removed and then treated with radiation in a single dose, all in the same procedure. Alexis Del Cid and crew have been documenting this case since early this morning. Let's check in with her briefly before we get going today. Alexis, tell us a little bit about the patient and, of course, how she's doing.
Oh, well, she had some nervous smiles happening earlier this morning, Jess. Her name is Leanna Doherty. She's in her 50s. She had her husband drive here from their home in Farlington, Kansas. She said she was hopeful. She was feeling the nerves, but who wouldn't be right now? Right now, she's on the table, on the operating table, and they're looking at her lymph nodes, in layman's terms, trying to figure out which lymph nodes they need to remove before this surgery. I said she was hopeful. She certainly has a lot to be hopeful for. She has a devoted husband who's in the waiting room. As you can imagine, he's probably really nervous right now. She has children who are grown. She has grandchildren. She has a career. So she is really hopeful to get back and going once this procedure is over. And it took a lot of specialists to get here. In fact, speaking of the doctors who are in this room making this all happen, in order to make IORT therapy possible, it takes 9 highly trained specialists, and they include a surgeon, radiation oncologist, a physicist, a specialty trained scrub nurse, a circulating nurse, a CRNA, an anesthesiologist, a pathology PA, and pathology staff. So there are a lot of moving parts in here, but the whole purpose of this is to perform this cutting-edge procedure that will make it so much more possible for Leanna, our patient Leanna, to get back to life as she wants to live it once this is over. So we're going to talk to some of those doctors, some of those specialists throughout the morning. Dr. Kelsey Larson is the surgeon who's performing. So, Jess, I'm going to toss it back to you in the studio, but if you see me do this, it means we have Dr. Kelsey Larson coming out to speak with us about how the procedure is going and how the procedure went, because they anticipate this to be easy and smooth. Check back in with us in a little bit, though, and we will update you with some of the specialists.
Okay, we will be on standby for your thumbs up, and Dr. Larson, thanks so much.
Okay.
All right, let's check in with Dr. Dana Hawkinson, Medical Director of Infection Prevention and Control. He is joining us here in the studio. Good morning to you.
Hi.
Hi.
Yeah. Numbers are pretty good, holding steady. 15 active infections, about the same as we were yesterday. 8 in the ICU and 5 on the ventilator. We still have 36 patients in that recovery period as well. So as long as we can hold those acute infections down, I think that's good. We know that the overall in the United States, the cases have been trending down now. We just need to keep that going.
Any reporter questions on the line today?
Sure. Good morning. Cody Holyoke with Channel 9.
Hey, Cody.
Hey, Dr. Hawkinson, you just mentioned you're seeing hospitalizations kind of pretty steady. New cases are dropping, and nationwide, that's an encouraging trend. We're not seeing, at least in our 2 states, a huge spike in vaccination numbers. I'm just curious your thoughts on where we are versus where we need to be to kind of get past the pandemic. Are you cautiously optimistic by the numbers that you're seeing right now?
You know, I'm certainly cautiously optimistic by the cases and the infections, but also the hospitalizations for sure. We know that the trend has been downturning, so that's always a good thing. But that's why I think it is time to encourage vaccination even more, because now we are in the downtrend of the latest surge. Hopefully we can protect ourselves against a new surge, especially now as we are going to be getting into the holiday season, and would certainly like to keep everybody healthy then, especially if you're planning to gather with friends and family during those times, whether it's Thanksgiving, New Year's, or Christmas, or any of those holidays or holiday seasons for group gatherings. Please go get vaccinated and really keep everybody in those gatherings safe.
Kind of a good point. And if you can expand on that, if you're pre-planning, I mean, it's a month and a half away from Thanksgiving, so people would really need to start now, I would imagine, on their course.
Yeah, go get your first dose. You know, your second dose should be in 3 to 4 weeks, depending on what vaccine you get, or go get Johnson & Johnson vaccine. That's just one dose. Any one of those is going to be really good, and it will set you up for immunity by the time you get to the holidays.
And then just last question for me. Of the patients that you're seeing, how are their ages? I know that they were trending younger over the past few weeks, but what are you seeing right now?
Yeah, we did see our average age of unvaccinated was certainly almost, I believe, 10 years younger than our vaccinated patients that we had seen. I don't have any of that demographic data now, but we can certainly try and pull those ages and demographics and, of course, vaccination status. I know yesterday out of our 15 patients, we had only one that was vaccinated, but as far as demographics of age and other comorbidities, I don't have that for this week, but we should be able to get that for you.
Well, thank you.
Other questions today? All right, we are going to get to community questions here in just a moment. And hey, I just want to welcome all of our Facebook and YouTube viewers in today. We are so glad you are with us. Also glad she is with us is Dr. Lori Lindstrom. She is a radiation oncologist here at the health system. She's going to kind of sit here with me and help us better understand the science of IORT. How are you today?
I'm great. Thank you.
Good.
Thanks for inviting me.
Good. You can kind of help me kind of co-pilot this
You
whole
bet.
procedure. I'm relying on you to help us understand what we're seeing and what we're doing in there, because I think you saw that and you were like, been there, done that.
Yeah, I've definitely been there, done that. So
we've done 100 of these, and you've been a part of how many about?
I don't think I've kept track exactly how many I've done, but I mean quite a few.
You've
I would
lost
say
track.
20, 25. I don't know. We have 8 radiation oncologists that provide IORT services, and we all split them up different days. So we have a team approach.
And we're way ahead of schedule on these,
Way
right?
ahead of schedule. Yeah, we have exceeded all expectations in terms of our numbers. We had hoped at this point in the year to be somewhere around, our original planning was about 2 a month. So, and we're reaching 100 at month 10. So we've had about 5 times the number that we initially expected.
So quite busy. And this
very
might
busy.
and this might be one of the reasons why, because if you watch our show, you may recall back in January, we featured a woman named Betty. She was the first patient here at the health system and actually in the state of Kansas to receive the IORT procedure. Betty was diagnosed with breast cancer during the pandemic. So that's difficult, as you can imagine. And then she had this single dose of radiation during her lumpectomy. It certainly added this kind of element of comfort for her, because it helped her feel safe, because she didn't want to have to keep coming back and making multiple trips back to the hospital for radiation. So it was a safer way for her to get her treatment, and certainly much more convenient. Dr. Lindstrom, I just want to kind of bring you in and talk about Betty. I actually received an email from her, by the way, yesterday, and she said that she couldn't be with us today, but she wished number 100 the very, very best. She says, I hope that her turnout is just as good, if not better than hers. She is doing great, and it was really smooth sailing for her. You saw her in post, right?
I initially saw Betty in consultation when we were trying to determine the best treatment course for her, and she was very interested in intraoperative radiation, and we thought she was an excellent candidate based upon our eligibility criteria, and so she was willing to be patient number 1. And then I saw her a few weeks after the procedure to see how she was healing, and she she just did great.
Yeah, I interviewed
fantastic.
her. There just wasn't a whole lot to talk about. She was,
No.
I just went in, I'm cancer free. I just feel great. She didn't have really a whole lot to add. She was just getting back to life. And I want to get this part out of the way, Dr. Lindstrom, because early detection is key, and not missing your screenings. I think Betty's story is interesting because she was actually going to skip she always did her mammograms, but was going to skip to try to stay safe from COVID. And our doctors have said so many times on here, don't let COVID get in the way of you taking care of your screenings and preventative treatment. So just kind of what's your message about that, and why it's so important that you're able to get these type of treatments?
Right. So we're seeing a lot of this where, early on in the pandemic, patients didn't know what was safe to do. We were, told to stay inside and mask and distance and pretty much not go anywhere for the first couple of months. And so a lot of women were late or skipped 2020 to get their mammograms completely. And so now we are seeing I see a lot of patients in clinic that say, I didn't go last year because of COVID, and now I'm here and have breast cancer. So our hope or our message is that, don't don't skip your screening studies. You know, breast cancer is best treated and cured when it's found early.
Okay, I did see a thumbs up from Miss Alexis. That do we have Dr.
good.
Larson? Okay, I saw a thumbs up. Give me another thumbs up when we have Dr. Larson. So tell me a little bit, Dr. Lindstrom, about any side effects. When I talked to Betty, she just didn't have any. Is it possible to have any side effects with this?
The beauty of IORT is there really are almost no side effects. I have seen, you know, of the how many patients I have treated in follow-up, and there's literally, you know, just about they tolerate it extremely well. There's always going to be potential side effects with any time you're having surgery, and then you add a radiation treatment during the operation. So there could potentially be issues with healing or infection. I always tell patients you could get a small skin reaction, you could get a little just local discomfort, or you could get a little bit of swelling around the treated area. But that's pretty much, you know, that's pretty much it, and it usually resolves within a couple of weeks if there's anything at all. Most patients are back up and doing life the way they want to do it within a couple of days of having the procedure.
Okay, so what if you are a patient elsewhere?
Yeah.
Let's say you have recently been diagnosed with breast cancer, or you have someone in your family who was diagnosed with breast cancer. We are the only one in the region,
Right.
only one in the state of Kansas that does this treatment and procedure. So what would be the next step if somebody wants to find out if they're the right candidate for this?
So my recommendation, if you or a loved one has recently been diagnosed with cancer, breast cancer, and are interested to see if you're a candidate or eligible for intra-operative radiation, that you come to KU for a second opinion or a telehealth second opinion, which we have both available through our navigators. And we can pretty easily go through your imaging studies, your pathology, and talk to you about what your options are. But many early stage women are good candidates for IORT.
All right, I think we are going to step back out into up at where all the action is, out to where our operating room, our IORT, our 100th procedure is happening right now. Alexis Del Cid is standing by. I think she's got some of our doctors who are going to tell us exactly what's going on.
My hope is to grab some of these doctors once they come out of the operating room, because we have planned to talk to Dr. Shane Steckline, who is the radiation oncologist, and Dr. Neba, who is the radiation physicist. These are two of the 9 specialists that need to be here for this procedure. One of the things before they come out here that I wanted to talk to you about is what makes this different from a typical breast cancer treatment. And one of the things that the surgeon, Dr. Kelsey Larson, told me ahead of time is that this completely enables the patient most of the time to go back to life as they know it at the end of this day. So our patient Leanna, they expect her to be back in time for lunch this afternoon, back in Farlington, Kansas, where her husband drove her in from. And here's why. They're going to use this IORT therapy to treat the cavity after they remove the cancer. And the hope is that it is small because they caught this early. They will give it a dose of the radiation. And what they're doing in here right now, once they do this treatment, will hopefully eliminate any need for those daily radiation appointments that we all know, breast cancer warriors who've had to go through this. They have their cancer removed and then they have to go back for the radiation 1 hour a day, every day, for weeks and weeks and weeks. The hope is this eliminates that. So Leanna can go back to life and be up and at 'em and doing her thing and not have to travel back and forth and get that radiation treatment. Let's take a look. Looks like they're moving that machine in right now. Now, I'm not an expert on the names of the equipment they're using because all the experts are in there working on this and monitoring things. So Jess, I'm going to hand it back to you in the studio so you can talk with our expert on the set about what we're looking at right now. But this is really remarkable to see in real time as Leanna is undergoing this treatment, this 100th IORT treatment.
Alexis, thanks so much for that update. Yes, I'm going to keep looking for your thumbs up. Try to grab those docs when you can, but we're going to stay in here with Dr. Lindstrom. So something that's interesting, and Alexis mentioned it, Doctor, about having so many people with different specialties. I've been inside ORs before, and there's people coming and going. But can you tell us why so many specific specialties are needed alongside this treatment?
So IORT is definitely a team sport, if you will, because it's championed by the surgeon. Obviously, we're doing a lumpectomy and sampling the lymph nodes at the time of the procedure, but it also requires a trained radiation oncologist and radiation physicist, which we normally would not have in the OR, during a lumpectomy. So it's definitely a team, a team effort, and we all have to see the patient beforehand. That's in our protocol, that we have consultations with both surgeon and radiation oncologist, so that we are very sure that we are selecting the right treatment for the right patients for this treatment option.
So before IORT, what would be the options for someone with an early caught cancer?
Right. So the main option for patients with early stage breast cancer prior to IORT was typically a 3 to 4 week course of radiation, about 15 minutes a day for 3 to 4 weeks, so 15 to 20 treatments in general is what is typical. And that's still not the wrong thing to offer. It's still accepted and standard of care. But because we are one of the only we are the only provider for IORT in this region, we can offer this specialized approach to radiation, where we deliver all of the radiation during surgery to the lumpectomy cavity, and about 90% of our patients don't need any further radiation. They are one and done, so to speak. So so that procedure takes care of their cancers.
Fantastic.
With a very low risk of recurrence, as low as if you'd had the external 4 week.
Yeah, the recurrence is key.
That's right.
So you're watching live inside one of our operating rooms where they are performing the 100th IORT procedure. We did the first one back in January, and you said we're about 5 times ahead of schedule.
Correct. Yes. When I initially saw Betty, I think it was very late December. She was our first patient. I think it was January 6th or something like that. And we expected maybe we would do 2 a month, or that's what we planned for. And it's been, like I said, 100 patients in 10 months. So.
What's it like when you
It's
talk?
extremely popular.
Yes, it is. And thanks to Betty. And like I said, we
Yeah,
talked to
thank
Betty
you, Betty.
yesterday, and she's so excited for this 100th. And I said, this is what you got started, Betty. This is what you've done. You've made us very, very busy. What's it like when you talk to a patient and you present them with a brand new therapy and say, you're going to be the first? That could be very exciting. Also,
Right.
a little nerves.
Right. Well, I would kind of start with, historically, you can, if you're a candidate for breast conservation, which is a lumpectomy, taking out the cancerous lump. Historically, you would be signing on for about 4 weeks of radiation in order to reduce your risk of recurrence as low as that of a mastectomy patient. But because we have this technology here, we can offer shorter treatment courses, even as short as 1 treatment with radiation during your operation. And so women are thrilled with that option. They're extremely excited. And some have sought us out as second opinions specifically for IORT, but most we present it during our clinic, and they're just thrilled that this could be an option for them.
And I think
1 treatment.
I think our first Betty that we've been talking about, she just thought, she was like, come again? What? This
Right.
can actually happen? I think she was gearing up to have to be coming in here, for 12 times over a 12-week period and getting her treatment. So she was really excited about it. Vicki has a question. She says, this seems like a game changer. Are we calling this a game changer, Doctor?
I think this is a game changer for women that are eligible. I mean, obviously not everyone's eligible, and we're very, very, very careful at KU to make sure we are only selecting patients that meet our strict criteria for IORT. But having said that, many women with early stage breast cancers are eligible. So I would encourage anyone who's interested to seek that second opinion at KU to see if they are eligible, because it is a game changer. Doing 1 treatment, not having any risk to your normal tissue and the rest of the breast or other normal tissues that we're trying to protect, such as heart and lung. So
One
it's a
and
game
done.
changer. That's right.
All right.
There's
So
Dr. Steckline.
Yeah, there's Dr. Steckline. He's taking a break from the OR. Alexis, I'm going to head out to you and let you take it from here.
oncologist who's observing and part of this cutting edge procedure. Dr. Stecklein, thank you for being here. You just said this is only going to be another 20 minutes?
Yeah, her treatment will be about 25 minutes today.
How typical is that compared to treatments in years past?
So the most common treatment for women with early stage breast cancer who undergo a lumpectomy is daily radiation treatments over 3 to 4 weeks. This patient's treatment will be 25 minutes, and she will hopefully be done with radiation therapy before she even wakes up from anesthesia.
And then can she go back to life as she knows it? What's the recovery time?
So in general, no different than a patient who just has a lumpectomy alone. She'll have some mild surgical restrictions at the very beginning, but she should be able to get back to her normal functional status very quickly.
We see people scooting by us, go on ahead. So what's happening right now?
So we use an ultrasound to determine the distance from the skin to the cavity. So they're just taking that instrument out of the operating room right now.
Is the IOR treatment appropriate for all breast cancer cases or just a small slice of them?
So it is not appropriate for everyone. We use very specific clinical and pathologic features to determine who's appropriate for this. In general, these are women who are 45 years of age or older. They have relatively small hormone-driven breast cancers. Their lymph nodes are negative, and they don't have any aggressive features on pathology. So it's not a small slice of women, but it's not appropriate for everyone. And our surgeons and radiation oncologists work together to determine who's appropriate and who we can safely offer this treatment to.
Dr. Stecklein, thank you. Now we're in a small space here, so I'm going to ask you and Dr. Nebaneba to trade places, and we'll let you get back to what you're doing. Dr. Nebaneba joins me now. He's the radiation physicist who is here. How does this system work, Dr. Nebaneba, once the cancer is removed?
The system comes in two major components. You have the treatment console that we see out here, and you also have the gantry inside the room on which the radiation source is mounted. And what happens is inside the radiation source, you have what we call it's an electron gun. It's simply a small system that when heated, it boils off electrons. Then electrons, you also have a linear accelerator. The electrons are accelerated by that linear accelerator. They travel down a drift tube, and at the end of the tip of the system, there's a goal target. The electrons interact with the goal target and convert them into photons, and then they come out and treat the patient. There's a lot more of physics going on in there, but that's how I can put it.
That's you simplifying things. This is what it's like talking to people who are way smarter than the rest of us. You have a picture that was very easy for me to understand, and I want to see if we can show our audience that, because this really helped me. So is this the part that then goes into the cavity once the cancer is removed?
Exactly. The physician, the surgeon, what they do is they measure the dimension of the cavity once the cancer is removed. And then from that measurement, they'll be able to tell us what is the diameter of that cavity. And then based off on that, we select the applicator that is exactly that diameter. And then we mount it on this X-ray source. Okay. And then we insert it inside the cavity.
So Dr. Kelsey Larson, who is the surgeon, has a whole bunch of these pieces, and the applicators are all different sizes. So she removes the cancer and then figures out which applicator, which this is like a ball on the end of this tip here, figures out which size best fits in the cavity, and then that's how you deliver the radiation?
Yes, these applicators come in from sizes ranging from 1.5 centimeter in diameter to 5 centimeters in diameter in steps of half a centimeter. So we have about a total of 8 of these applicators. So once the cavity size has been determined, we pick the applicator that fits that cavity size, and then we mount it on the system and we insert it in the cavity and treat.
Dr. Nebaneba, thank you so much for being here, radiation physicist. Let's check back in and see. It looks like the procedure is over. I think Dr. Kelsey Larson is somewhere. Is she getting ready? Can we talk to you, Dr. Larson? Excellent. Come on over here. Again, we're working in small quarters, so I'm going to have you stand right next to me. Dr. Larson, how did it go?
Everything went fantastic, better than expected, actually. So she is just an ideal, perfect patient for this type of treatment. And we're so happy because when we see these patients like her who have these small and early stage breast cancers, this is absolutely the perfect choice for their treatment. So everything's going wonderfully.
Did you know instantly that this was going to be perfect? At what point were you looking at her once you got in there and thought, okay, this is going to work out great?
Yeah, I'm a little superstitious, so not until we're actually almost all the way done do I go, okay, this is going good. So don't want to put the cart before the horse, but everything's going wonderfully so far.
When we talk about catching cancer early and that being the ideal patient for the IORT procedure, early as in the smaller the tumor, the better for the patient and for this therapy?
Yes, exactly. So the treatment has a specific anatomic cutoff because we have certain applicators in certain sizes. And so there just are rules and restrictions for what we can do and how we can accommodate this. And so people have to have a small early stage breast cancer to get this treatment.
So what happens next?
Yeah, so this is a team-based effort. So while I was performing the operation, our radiation oncology colleagues were out here preparing the equipment. And now we've finished with the lumpectomy portion of the surgery and put the radiation applicator in the cavity. So over next to us, you see that they're making sure the equipment is working and they're entering the prescription for us. And then they're going to go ahead and start the radiation treatment once that prescription's entered. And I think they're about ready.
Okay, we're ready to go. So, Dr. Larson, thank you. We're going to watch now. Now, this is going to look pretty calm, this part, right, Dr. Larson?
Yeah, this is a little bit of the quiet part of the procedure, at least for us, as long as we get the treatment started and everything's going well. And they'll sometimes tease and say it's coffee break time, but we just stay right out here outside the room, making sure everything's functioning and just monitoring the patient while they receive their treatment.
Okay. Thank you, Dr. Larson. This is such a remarkable event. So let's take a look at how this next part works. You see Dr. Neba and Dr. Steckline at their machine, making sure everything is ready to go. Everyone has left the room except for an anesthesiologist who is behind a lead curtain, behind a lot of lead, so that they're not exposed to the radiation. And I'm just going to watch with the rest of you guys who are watching at how this works. But this has really gone beautifully by all accounts today. And it's almost over, Jess, as I toss it back to you in the studio. They're going to start this treatment at 8:28 is the time that Dr. Steckline just gave.
Fantastic. I can't believe we started our show. They've actually done this procedure in a less time than it takes Dr. Stites to get through like all of the stuff that he talks about on our show every day. So it's crazy to think that this procedure has wrapped up and you guys couldn't have timed that out any more perfectly. And Dr. Lindstrom, when we talked before this happened, and I know you've been in there, you said you've been there, done that. You've done so many of these procedures. And I have to say, I'm very happy that Dr. Neba had pictures to help all of us understand exactly what's happening. It's so fantastic to watch this. And I have to ask you, what is it like for you? You've been working and treating women, and I say women with breast cancer. We know that men have breast cancer, and it is very rare. But what's it like when a woman comes out, you're able to take and ease that burden for her and say that you are done with this treatment now that this is now available?
Yeah, I mean, it's a win-win for us and for them, and especially for them, of course. So what we have to wait for the pathology to come back, and that takes just actually a couple of days, and then we typically see the patient back a couple of weeks after treatment, see how she's healing and how she's doing, as well as review the pathology and make certain there aren't any indicators in that pathology that would require additional radiation. But like I said, 90% of our patients, I believe, have been one and done, and that intraoperative radiation ends up to be the only radiation that they need, which is fantastic because it's sparing all of your normal tissue.
And what is that right there that he's holding?
That's a Geiger counter. So Dr. Neba is checking the surrounding area to make sure that we are looking at if there's dose leak outside of the room and where it is, so that we keep everyone outside safe and away from the radiation source. And you can see he's got some radiation stickers on the window to not enter the room during the procedure. So everyone's out of the room except the anesthesiologist, who is behind a lead shield.
So the anesthesiologist is kept very, very safe, correct?
Yes, very safe. Yes.
So as we watch this 100th IORT live procedure, we know that this is the 50th year anniversary of cancer treatments, Dr. Lindstrom. And just to watch this happening during a year that we're celebrating all the advancements over the last 50 years, what's that like for you?
It's both. It's so exciting. It's just really. When I started out in practice, our typical treatment course for breast cancer was 6 or 6.5 weeks, daily radiation, not very precise, not very accurate. I mean, I hate to say that now, but looking back, that is the reality. And so we have made so many advancements in the field of breast cancer, and it's every single one has been so exciting. Every time we can reduce the number of treatments a patient has, the better efficacy of the treatment, as well as reducing dose to normal tissue. It's extremely exciting. And we've really been able to do a lot of that in the last 20 years.
And you've been a part of it.
I have.
We've got a lot of
Happy
great
to say.
comments and questions coming in. First of all, Jerry says, the one thing that I notice is that everyone on the team is wearing a mask, eye shields, as they operate, as they've always done in operating rooms. Can't understand why there's so much opposition to wearing masks. That's something we've said here on the show so many times with COVID, is that this is exactly what our doctors have been doing for years and years, since we could, at the beginning of time, and doing operations, that people have been wearing masks. Is that what they do? So
we learned about 150 years ago that wearing masks and goggles actually keeps patients safe and from acquiring an infection.
And they work, and they do it, and here they're doing it for a very short amount of time,
Exactly.
only about 30 minutes or so. But I mean, these are surgeries that often take hours and hours and hours.
That's right.
So if they can do it, you can do it. Emily says, thank you to the patient for agreeing to share her procedure and story.
Yes.
She's hoping for a full and speedy recovery. And thanks for just talking more about this today, this IORT, and just letting our viewers know that this is available. I think if we don't talk about these treatments, then people don't even know to ask the questions to their doctors.
Well, most patients, when they're newly diagnosed, don't know what questions to ask. That's a real common. I said, do you have questions? Well, I don't know what to ask. So
you asked them for, tell me.
Our job is to educate and to let you know what your options are, and to help bring you into that decision as a patient to see what the best treatment is for you.
What are a couple of top questions you would have? I mean, the emotion behind breast cancer and any type of cancer diagnosis is immense. But if you're sitting down with somebody for the first time, what are a couple things you want them to consider and be thinking about?
Well, I mean, our focus is on curing the cancer, so we want to make sure that we're talking about what is the best way to cure this cancer, and what surgery do you need, and adjuvant treatments such as radiation, and sometimes other oral therapies or chemotherapy. And we also want to give them, I think one of the things we do so well at KU in our breast program is our team approach, our multidisciplinary team approach to breast cancer, because time and time again when we see patients together in clinic, and so a patient will come in and see the surgeon, they'll see me, they'll see the medical oncologist, and they have questions, they have concerns, they have anxiety, and each of us do our teaching, and by the time they leave, they feel like they have a game plan, they feel like they have peace of mind, that their team is going to take care of them, and that they're the central part of that team, and they're so thankful for that. So, we anticipate questions about, cure rates and side effects and procedures and all of that. And patients listen, and they often have other questions that come out of our explanations to them. But the main thing is they leave and say, almost everyone says, I feel so much better than when I came in.
That's all you can do.
And that always makes me feel great.
I bet it does. We are live. You are looking right now live outside of the operating room for our 100th intra-operative radiation therapy, also called IORT. We're going to check in with Alexis here in just a moment. But a question that Jean had is this type of treatment good for other types of cancers?
Well, it can be. Right now at KU, we're just focused on breast, but there are some centers that are using it for some other types of cancers. And, traditionally, there have been opportunities to use it for some abdominal cancers. And we haven't expanded our program to that area yet, but, just wait.
We got to
You never
wait
know.
for the next 50 years.
You never
More
know.
to come.
Yeah.
So another question Vicki has, going back to the 9 specialists that it takes to pull off this procedure. We talked about it at the beginning of the show, but just go over that again. Is that a normal amount of specialists, or is it because this is such an advanced treatment that you need so many, as we call them, smart people up there with all hands on deck?
Well, it does take, it's a huge amount of investment in the time of all of our specialists, because we're all there as a team, and so yes, it is additional, it is additional physician and physicist time above and beyond what you normally have. We have to have a pathologist on call, because every single time the surgeon takes out the cancerous lump, they send it to pathology. The pathologist looks at it, makes sure it looks like we're all around it, because we want to make sure we have good clearance in our lumpectomy specimen. So the pathologist is on the ready to look at everything. Prior to the procedure, we've put a little tiny seed inside the tumor, so that the surgeon can localize it. So it's a huge team effort, and so I'm a huge believer that all cancer is best treated with a team. So yeah,
Right.
yeah.
Everybody
So
working together.
Everyone works together
to
and
rid
there's
the
a
body.
Tremendous amount of great collaboration on our breast team.
Isaac has a question.
Yeah.
See if you know this one. How many women are convinced that they have breast cancer because mammograms might have picked up a swollen lymph node that might have been brought on by the vaccine?
Well, thankfully, we have expert radiologists that help us sort through that. So we ask the question about, when was their vaccine? We know it can give you some swelling in your lymph nodes under your armpit that can be sometimes confused with cancerous lymph nodes. And our radiologists will usually do ultrasound, and sometimes we do MRI to try and discern, an abnormal lymph node from cancer versus an abnormal lymph node from COVID. And our radiologists really help us with that.
So, and there's no way to tell, like, let's say you let's just say you're doing your own self-breast exam and you feel a lump. That doesn't necessarily mean cancer.
No, it
but
doesn't.
if it is a lymph node, you still need to have it checked out. Is that correct?
Correct, right. I would say a swollen lymph node that is large enough for you to feel, you should bring to the attention of your physician.
Absolutely.
And follow up on it. I mean, we have, typically 20 to 30 lymph nodes under our armpit, and most of us never feel them until they get either infected or sometimes have, cancer in them. So yes, I would always recommend following up on that.
Okay, and for those who are just joining us, about how long did this process take? We're going to get to our final thoughts here in a moment, but you're watching the tail end of our 100th IORT treatment here at the health system. About what from start to finish?
So start to finish would be putting the patient to sleep, you mean? Okay.
Yeah.
To finish, about an hour and 15 minutes.
Okay.
Yeah.
And then once
To
the
an hour
docs
and a
get in
half.
there, about a half hour?
And about the actual radiation piece of it is going to depend on the size of that sphere that fits the lumpectomy cavities. So it could be anywhere from, about 17 minutes to 30 minutes.
So they'll know
extra
once they
time.
get in there.
They'll know once we get in there, so we size the lumpectomy cavity. But I tell patients we're going to add about maybe up to another 30 minutes to your operating time, but you'll be taking a nice nap. So and you'll be able to go home as soon as it's done.
Wake up from a nice nap and ready to go home.
Yeah,
and
they'll feel great.
Fantastic. Okay, so we're going to get to our final thoughts. We're going to head back out and talk to Alexis here in just a moment, but I'm going to go ahead and get final thoughts from you, Dr. Lindstrom. Just what do you want everyone to know about just taking care of their health, taking care of their breast health, and just asking those right questions?
Yeah, I think mainly being diligent about getting screening exams, because we still don't know exactly how to prevent breast cancer in general, and we know some things about diet and exercise and things like that, but a lot of it is out of our control. The older we get as women, the higher risk we are. So doing your screening exams is so important, because that allows us to find cancers when they are truly really small and I tell patients that gives you a whole menu of options as to how to best treat it. It's not a one-size-fits-all. It's highly personalized, but we go for a cure in most of our patients, and there are lots of options. So
Thank you for co-piloting this day with me.
Thank you for the invite.
Absolutely. You're welcome back anytime. Thank you so much.
You bet.
Alexis, I want to head out to you and get some final thoughts from outside the operating room. How's it going?
It is going fantastic. What a morning. I have Dr. Kelsey Larson here. Dr. Larson, 12 minutes and 30 seconds left of the procedure, and then she's done. What are your final thoughts on this?
We are just so thrilled and so happy to be offering IORT at our center, and it is such a wonderful opportunity for our breast cancer patients in the region, across the state and across the multi-state region. And so I'm really appreciative of all the teamwork that went into this and everyone who comes together to give the best care possible for our patients.
You have another one scheduled for later today.
Yes, ma'am. We're very happy to keep offering them and keep giving this wonderful treatment to as many people as possible.
Less than 12 minutes, and our patient Leanna is ready for recovery. And Dr. Larson, you said she'd be home in time for a late lunch. That's right on target.
Yep, that's what we aim for, is a smooth surgery, smooth treatment, wanting to make sure that, although it's a diagnosis no one wants, that it's a good experience in terms of treatment and wonderful care.
Wonderful care. That pretty much sums it up here. Back to you.
Alexis and the whole team, thank you so much for sharing this experience with us. Dr. Hawkinson, you kind of got the morning off a little bit.
Yeah,
sorry, people had a lot of questions about what's going on, but but I do want to hear from you. And what are your final thoughts for folks out there today?
Prevention is the best medicine. You know, getting screened for cancer, breast cancer, colon cancer, doing those preventive things. Some of the best prevention we have are vaccinations against a variety of things. The shingles vaccine, pneumonia vaccines, influenza vaccine, tetanus, and of course, COVID-19. We know that there's been a lot of news about the new oral pill that may or may not be coming out. You know, you still continue to roll the dice anytime you get the infection, but the best measure to protect yourself against hospitalization, severe disease, continues to be those preventive measures, especially vaccinations. So please go get vaccinated and go get screened for cancer.
All right, Doc Hawk, thanks so much. All right, just a final look at our 100th IORT treatment here at the health system. We did our first one back in January, and we are now 5 times ahead of schedule.
It's definitely a milestone, and women love it, and we love to be able to offer it.
And you're going to be back in the OR on Thursday, right?
That's right.
Back at it again.
Yeah.
All right.
I'm the Thursday team.
You're the Thursday team. All right. Thank you so much for being with us. And thank you all for being with us today. Tomorrow, Open Mics with Dr. Stites is back. What started out as a way to stay safe during the pandemic, telehealth has become convenient and a whole new way for us to visit our doctor. But this new way of doing it may be in danger of going away. If you are liking telehealth and checking up with your doctors virtually, then watch and find out what you can do to help. Join us tomorrow at 8 o'clock and have a great day.
Subscribe to our Morning Medical Update and Open Mics with Dr. Stites podcasts. Now everywhere podcasts are available.